Hello everyone. So today we'll be taking pharmacology MCQs. We'll be focusing on analgesics. As you know, analgesics are known as painkillers. So my list of questions for today would occupy or come in four sections: opioids, NSAIDs, paracetamol, and analgesic adjuvants. Let's begin. Our first section will be opioids. First question: which opioid receptor subtype is primarily responsible for supraspinal analgesia, euphoria, and respiratory depression? A. Kappa, B. Delta, C. Mu, D. Sigma, and E. Nociceptin or ORL1. And the answer to this question is C. The Mu receptor is the one that will carry out this function in particular. That's C. Next question. A patient on long-term morphine develops tolerance. The mechanism underlying opioid tolerance primarily involves A. Downregulation of opioid receptors, B. Receptor desensitization via the G protein uncoupling and receptor internalization, C. Increased hepatic first pass metabolism, D. Upregulation of adenyl cyclase, E. Both B and D. So, which of the following is involved in tolerance of opioids in patients? And the answer to this question is is E. That is both B and D. Moving on to the next question. Morphine active metabolite responsible for its prolonged effects in renal failure is A. Morphine 3 glucuronide, B. Normophine, C. Morphine 6 glucuronide, D. Codeine, E. Hydromorphone. So which of these do you think is responsible for the prolonged effect in patients who already have renal failure? And the answer here is C. Morphine 6 glucuronide. To the next question. Which opioid is preferred in renal failure due to lack of the active metabolite accumulation? A. Morphine, B. Codeine, C. Tramadol, D. Fentanyl, E. Pentadine. And the answer here is D, which means that fentanyl will be preferred in patients who already have renal failure. If a patient has renal failure, their body will not be able to excrete the drug, so the drug will likely accumulate. But now, fentanyl is good because it lacks that active metabolite that usually accumulates. The next question. Pentadine is avoided in patients on monoamine oxidase inhibitors because it can cause A. Hypertensive crisis only, serotonin syndrome, and satiety, C. Respiratory alkalosis, D. Peripheral neuropathy, E. Hemolytic anemia. So what's the answer to this question? The answer here is B. Serotonin syndrome. Moving on to the next question. Number 6 question. A postoperative patient receives pentadine and develops tremors, myoclonus seizures. The toxic metabolite responsible is what? A. Norpentadine. B. Petadinic acid. C. Meperidinic acid. D. Fentanyl. E. Morphine 6 glucuronate. And the answer here is A. No, pentadine. Moving on to the next question. Number 7. Which opioid is used as a cough suppressant and acts as a prodrug requiring CYP 2D6 for conversion to morphine? A. Tramadol. B. Codeine. C. Hydrocodone. D. Buprenorphine. E. Dextromethorphan. So what's the answer here? Which one is used as a cough suppressant? An important thing that you almost know that the opioid that is most times used as a cough suppressant is codeine. The answer is B. Number 8. Tramadol mechanism of action includes all the following except A. It is a weak mu opioid receptor agonist. B. Serotonin uptake inhibition. C. Norepinephrine reuptake inhibition. D. NMDA receptor antagonism. E. Sodium channel blockage. So, which of the following does tramadol not use as a form of mechanism of action? And the answer is E. Sodium channel blockage. Number 9. Buprenorphine is a partial agonist at the mu receptors. Its ceiling effects on respiratory depression is clinically important because A. It causes more analgesia at higher dose. B. Respiratory depression does not increase proportionally beyond a certain dose. C. It completely reverses all opioid effects. D. It has no analgesic ceiling. E. It activates delta receptors at higher doses. So this is a tricky question. What do you think the answer is? Don't guess. Try and look at the options. Try to eliminate. And the answer for this question is B. Respiratory depression does not increase proportionally beyond a certain dose. Number 10. Which opioid has the highest oral bioavailability due to minimal first pass metabolism? A. Morphine. B. Codeine. C. Methadone. E. Oxycodone. E. Fentanyl. Which one has the highest oral availability? And the answer is C. Methadone. Number 11. The opioid antagonist naloxone is preferred over naltrexone in acute opioid overdose because A. Naltrexone has a longer duration of action. B. Naloxone has a shorter duration, allowing titration. C. Naltrexone causes more vomiting. D. Naloxone is selective for mu receptors only. E. Naltrexone is not bioavailable entirely. And the answer here is B. Naloxone is preferred because it has a short duration of action. Number 12, tapentadol differs from tramadol in that A has stronger serotonin reuptake inhibition, B has weaker mu opioid agonism, C has stronger mu opioid agonism and no serotonin reuptake inhibition, D requires CYP2D6 activation, E is an NMDA antagonist. And the answer here is C. So tapentadol differs from tramadol because tapentadol has a stronger mu opioid. The opioid has about 3 receptors: the mu, the kappa, and the delta receptor. So tapentadol has a stronger mu opioid antagonism. So we'll move on to the next section. In our next section, we'll be looking at questions on analgesics that are under the broad class of NSAID, that's the non-steroidal anti-inflammatory drugs. Moving on to the next question. Question number 13. The analgesic and anti-inflammatory effects of NSAIDs are primarily due to inhibition of A. lipoisogenase, B. phospholipase A2, C. COX-2 and COX-1, D. Thrombosin synthase, 5. LOX pathway. Which of the following pathway is inhibited for the NSAIDs effect to take function? It's a very obvious answer. The answer is C. NSAIDs inhibit the COX-1, the COX-2, and even the COX-3 pathway. Number 14. The gastroprotective mechanism of misoprostol when prescribed with NSAIDs involves A. H2 receptor blockage, B. Proton pump inhibition, C. prostaglandin E2 analog action stimulating mucus and bicarbonate secretion, D. Antacid neutralization, E. Selective COX-2 inhibition. So, gastroprotective, the answer here is C. It has a prostaglandin E2 action, stimulate the body, stimulate the GI tract to produce more bicarbonate to neutralize the acid, and mucus to protect the gastric line. Is given to patients. It's among the drugs given to patients who have peptic ulcer to protect their gastric lining so as to prevent more corrosion by the drugs you take. The next question: a patient on aspirin for cardioprotection is started on Ibuprofen. The concern is A. Increased GI bleeding only, B. Competitive antagonism at COX-1, reducing aspirin antiplatelet effect, C. Additive neurotoxicity, D. Serotonin syndrome, E. Increased aspirin metabolism. And the answer here is what? The answer here is B. Competitive antagonism at the COX-1. Number 16. Which NSAID is most COX-2 selective and was withdrawn from some markets due to cardiovascular risk? A. Ibuprofen, Diclofenac, Ophecococcyps, Celecoxib, Ketorolac. And the answer is C. Ophecococcyps. Number 17. Aspirin at low dose of 75 to 150 milligrams is used for antiplatelet therapy, the mechanism involves A. Reversible inhibition of COX-1 platelet, irreversible acetylation of COX-1, blocking the thrombosin A2 synthesis. C. Inhibition of platelet ADP receptors. D. Direct thrombin inhibition. E. Fibrinolysis activation. The answer is B. B. Irreversible acetylation of the COX-1 blocking thrombosin A2 synthesis. Question 18. Ryan syndrome is a recognized complication of aspirin use in children with viral illness. The pathology primarily involves A. Renal tubular necrosis, B. Hepatic mitochondrial dysfunction and encephalopathy, C. Hemolytic anemia, D. Aplastic anemia, E. Cerebral edema without hepatic involvement. So, there are two very tricky answers in this option, and the answer here is what? Is B. Is B. Moving on to the next question. Ketorolac is notable among NSAIDs for which property? COX-2 selectivity, potent parenteral analgesic comparable to opioids for short-term use. C. Long half-life suitable for once daily dosing. D. Safe use in peptic ulcer disease. E. Minimal renal effects. And the answer is B. Potent parenteral analgesic comparable to opioids. Number 20. Which NSAID undergoes enterohepatic recycling contributing to prolonged GI toxicity? A. Ibuprofen, aspirin, piroxicam, ketorolac, celecoxib. And the answer here is C. Moving on to the next section. This section will be paying attention to paracetamol, that is acetaminophen. Let's begin. Question 21. The mechanism of paracetamol analgesic action most likely involves A. Peripheral COX-1 inhibition, central COX-3 inhibition and activation of descending serotonergic pathway. C. Opioid receptor agonist. D. NMDA receptor blockage. E. Kappa receptor partial agonism. And the answer is B. In paracetamol overdose, hepatotoxicity results from accumulation of what? A. Para-aminophenol. B. NAPQI. C. Phosphate conjugate. D. Glucuronate metabolite. E. Metcaphtoric acid. The answer is B. Number 23. The The antidote for paracetamol overdose, N-acetylcysteine, works by, and the options are directly neutralizing NAPQI, replenishing glutathione stores, inhibiting cytochrome 2E1, both A and B, E, activating glucuronidation pathways. And the answer is D. Both option A and option B are correct. Number 24. The 4-hour serum paracetamol level used in the Romac-Mathieu nomogram to guide NAC therapy is A. 50 mg per liter, 100 mg per liter, 150 mg per liter, 200 mg per liter, or 250 mg per liter. And the answer is C. 150 mg per liter, which is the treatment line threshold. Now down to the adjuvant analgesics. Question 25. Gabapentin and pregabalin produce analgesia in neuropathic pain by A. GABA-B receptor, by binding to GABA-B receptors, blocking voltage-gated sodium channels, binding to alpha-2 delta subunits of voltage-gated calcium channels, inhibiting NMDA receptors, or enhancing glycine as spinal dorsal horn. And the answer is C. Binding to alpha 2 delta subunit. Question 25. Amitriptyline is used in neuropathic pain. Its analgesic mechanism, independent of antidepressant effect, involves A. Serotonin reuptake inhibition alone, norepinephrine reuptake inhibition, sodium channel blockage, GABA potentiation, mu opioid receptor agonist, COX-2 inhibition. And the answer is B. Move on to the next question. 27. Ketamine produces analgesia primarily through A. Mu opioid receptor agonism, alpha-2 adrenal receptor agonism, non-competitive NMDA receptor antagonism, sodium channel blockage, cannabinoid receptor agonism. And the answer is C. Non-competitive NMDA receptor antagonism. Question 28. In the WHO analgesic ladder, which class of drug occupies step 2? A. Non-opioids only. B. Strong opioids. C. Weak opioids plus non-opioids. D. Adjuvant only. E. Cannabinoid. The answer is The next question. Ziconotide is given intrathecally, that is through the bone, is used for refractory pain. Its mechanism of action is what? A. Mu opioid receptor agonism. B. N-type voltage-gated calcium channel blockage. C. NMDA receptor antagonism. D. Alpha-2 agonism. E. Sodium channel blockage. And the answer is B. N-type sodium-gated calcium channel blockage. And to our last question, which is the last but not the least. A patient on opioids for cancer pain develops opioid-induced constipation, that is OIC. The most appropriate treatment that does not reverse the central analgesia is A. Naloxone oral, methylnaltrexone. C. Lactulose only. D. Naltrexone. E. Reduce opioid dose. And the answer is B. Give the patient methylnaltrexone. It acts peripherally on the mu opioid receptor and causes antagonism of their action. So all these things like euphoria, they will not occur. So this is the end of the question for today. Thank you for following me. To master all the questions and answers that I have presented, you have to watch the video, you have to watch two times, and you have to master the art. See you in my next video. Thank you. Kindly subscribe.